to move on. So perhaps that question that she was alluding to, we can incorporate it further on in the discussions. At this point, I'd like to start our second round. Dominique, with the Conservatives, vous avez 5 minutes.
Merci beaucoup. Que d'intelligence.
Thank you very much. Such intelligence today. We often have this, but really today around the table, we have men and women who are truly inspiring. Thank you for your presence and your testimony. I'll try to speak slowly so that you will understand me well. First of all, I'd like to say that I have had personal experience that I won't talk of here, but my colleagues are aware of it. But also, amongst my close friends, I have friends in their 30s who have had to have double mastectomies. And you're saying that more and more young women are grappling with breast cancer, and that's true. Anna spoke earlier about a case where there is cancer present in one breast and the other is healthy, that the person might decide to remove both. So we can see to what degree these can be situations that are really difficult. I was surprised this morning, and in the reading that I've done, that we talk about harms. When there is early screening done. So really, I couldn't believe it, because I thought I've been having mammographies since I was a young woman. It's been some time. So how is it possible we're talking about harms associated with screening? Could you explain this to me? Because I don't understand it. How can that conclusion be arrived at? Dr. Apavu, I hope I pronounced your name correctly. What are the disadvantages? What are the harms of undergoing early screening? I can't believe that it's only that you might get a phone call and be called back. I had that experience, and I was very happy that I was asked to do so. So what are these harms that we're taking into consideration for this group?
Question. There are a few. Everything has pluses and minuses. And there are a few downsides to screening. One of them is, you might, about 7 to 10% of women who get a mammogram may get called back to have a second look. Most of those, about 95% of those women, will get a double check and be able to, breathe a sigh of relief and go home knowing they got a little bit of extra care and attention, and they're good till their next screen. Most of them will be fine. And that is, it's not, I don't like to diminish the worry that is. I mean, mental health is important as well. I don't diminish it. But in comparison with a delayed diagnosis, I think it's trivial. That's my own personal opinion about that. But I would say there is a more significant harm in the form of something called overdiagnosis, which is essentially the chance that your cancer was found. You poked the bear, you went looking, hunting for a cancer, and you found one. But that cancer could have sat there until you died of other causes, and you would have never had to have the treatment. And the treatment itself is, unpleasant, to say the least. And however, the good news is for the youngest women, that is a very trivial likelihood, around 1% or less than 1%. And what that is because your chance of your cancer sort of, you outliving your cancer basically, is based on the fact whether or not that cancer is aggressive. So is it one that's going to grow? And then also, how much lifespan do you have left? So on the one extreme end, if you do a mammogram on somebody who's 85 and she's got heart disease, that's overdiagnosis. But somebody's 40, it's not going to...
J'ai peu de temps.
I'm sorry, I have little time. I'll have to interrupt you. I do apologize. You said earlier we should dismantle the working group and appoint a different one. So what are the main reasons that bring you to that conclusion, and who should be part of that new committee, that new task force?
New task force, I think that, first of all, it's not for me to actually do that. I think, that would be a project of its own, but we do have some recommendations. There is, I think that we need to rebuild it with accountability, We need to rebuild a new task with accountability, with transparency, and with experts. And the idea of bias, eliminating the need for experts, is based in a logical fallacy, an ad hominem attack, an appeal to motivation, which is, as if any of you, I'm sure most of you've debated here at some point, it's really not a valid argument. Bias, everybody's got bias. There's some sort of bias in everybody, and you have to work around it. And you can't throw out expertise in trying to eliminate bias.
Merci, Dominique. Oui.
Thank you, Dominique. 5 minutes. I'm sorry.
Okay, next we have Emanuela, 5 minutes.
Thank you, Madam Chair, and I'd like to thank all of our witnesses for being here today. All of you are great, but Dr. McCurley, Dr. Rushton, and Dr. Apavu, I want to particularly thank you because I was the person who submitted your names in, and Jenny Dale was the one who had sent me your names from Dense Breast Canada, and so in honor of her and of all of the women fighting to improve the outcomes for women with dense breasts, I'd like to ask you, if there's any evidence that has come out in the last decade that you think should have been considered by the task force when putting out the report? Because in the report, it actually says that for women with moderately increased risk due to high breast density, they didn't find evidence of benefits of supplemental screening. And that's not what we heard today. So if anybody can explore that a little bit more and provide some more details, that would be great. For a first question. Yeah, go for it.
I'll just start by saying, yeah, they did put it in the guidelines, and there's been a lot of research that's been done in the States to show that women with dense breasts have at least a 4 to 6 times higher risk of getting breast cancer. If you add MR to supplemental screening, I think you pick up at least 80% more cancers that would, in a mammogram would have been normal, and if you add ultrasound, you'd pick up at least 50% more. So there's for sure some evidence to show that supplemental screening would help pick up more cancers, and that should have been factored into guidelines. Stop there.
Dr. Rushton?
So in discussion with one of my colleagues is that part of the issue with a lot of these studies is that the endpoint perhaps is not the right endpoint we need to look at. The endpoint is often a hard endpoint of survival. Instead of looking at the stage migration that we achieve with early detection, there have been, I would disagree with the chief surgeon from Manitoba who indicated that the treatment of stage 1 and 2 breast cancer is essentially the same. Historically, that may have been true, but every year we're achieving advances in systemic therapy of breast cancer where that's no longer the case. Even in the worst actor of triple-negative breast cancer, where even a small sub-centimeter no-negative tumor gets chemotherapy, one that's larger than 2 centimeters or has lymph node involvement will have immunotherapy and a more aggressive chemotherapy. Systemic therapy is really working to de-escalate treatment where we can in earlier stage disease, but also very much escalate for stage 3 disease across the board. So stage does matter, and I think endpoints matter, and that's the problem with the evidence review and the lack of expertise is that there's no one there to put it into context of what it means to treat breast cancer today.
Emanuela, Dr. Hubbard would like to contribute as well. Okay.
So I actually take a look at the composition of the task force. It appears that there are quite a few women. It seems like it's almost equal in women and men. However, there is only one Asian woman and one Asian man, and besides that, everybody is white. Do you think that that had any effect on what those recommendations looked like?
I can answer that. I don't think there was actually any women of color on the working group that actually addressed breast cancer. I'm not sure that is. I don't think that necessarily influenced what they said. I will, grant them that they weren't making, racist recommendations because there were no people of color were in the room. But I do think that it's symbolic of a disregard for racial equity. And one of the things that I think is also indicative of that is their use of grade to elevate the ancient RCTs above the observational studies. All of those RCTs were done from the 60s to the 80s on 98% white women. And they put that evidence as the top level of evidence, and everything else, which may have been much more diverse, was given a lower importance. And so there's a systemic form of racism there. So I think the fact that there were no women of color on the working group is possibly a symptom of the same disease.
Thank you very much. And I don't have much time, but I would like for any stats that you can send to the committee on dense breasts, any facts that we can include afterwards in our report. By what day do they have to submit?
Tomorrow or the next day.
By tomorrow. So if at some point today you could send in some statistics on dense breasts that you mentioned, Dr. McCurley, and anything else that you have that would help us send the right information to the task force, because this is what's going to happen with this study. It's going to end up being sent there so that they can consider this.
Perfect.
Please do send it in.
Thank you, Emanuele.
Thank you.
Next, Adrienne, you have 2.5 minutes.
Oui, merci beaucoup.
Thank you very much, Madam Chair. Just before moving on, you have all studied this question in depth. Are there any of you who've been consulted by the working group, the task force, rather? Okay. Ms. Sienna? You were consulted? Okay. So,
Online, just so you're aware.
Parfait. Donc, désolé.
okay, I'm sorry, I couldn't see her hand. Thank you, Madam Chair. So perhaps I'd like to hear from you if you were consulted. What did you have the opportunity to say to the task force? And just quickly, because I don't have a lot of time. So starting with Ms. Sonia and then online.
Very much for the question. We were consulted along the way. For us, it was really important to ground this entire experience in just what patients are experiencing, and just making sure that as part of their considerations as they were building out their guidelines, that the patient experience was front and center for their considerations, and to make sure that we were being holistic in that approach.
I can speak to I was one of the expert advisors on the evidence review, and the advice that we provided was rejected by the task force on multiple occasions. And anyone who was able to be an advisor to the working group had to sign a disclosure, non-disclosure. They could not disclose what their input would be. It was something that I did not do for that reason, but I can tell you that on numerous occasions on the evidence review panel, we could see the lack of understanding of the screening and the understanding of the studies that we were talking about, so that it was really not well regarded and not well taken into consideration.
OK, excusez-moi, je suis un peu sous le...
I'm sorry, I'm pretty shocked. You're making recommendations. You've been consulted. You're not taken into account. You're asked to sign non-disclosure agreements. I only have a few seconds left. It's incredible.
Okay, thank you, Adrienne. Leah, you have 2.5 minutes.
Or 3. Just kidding, Chair.
5 minutes, Leah.
Thank you so much. I agree with my colleague, Adrienne LaRouche. It is totally shocking, especially this whole notion. It's like this hysterical woman's syndrome. We know that the healthcare system has historically reeked of sexism, which is why I asked the question. I certainly don't think that representation doesn't exclude expertise, but to have other folks making decisions about my body as a woman, I'd like to see some women around the table, and certainly women around the table that reflect my background, my ethnicity. So in saying that, I want to actually ask Dr. Seeley a very basic question, yes or no, and then I want to ask you another question. In Nunavut, do you think it's critical that they immediately implement a breast screening program? Yes or no? Yes. Okay.
Yes.
So so you would recommend that?
Yes, in fact, I do interpret those mammograms, and I've been working to try and implement this in Nunavut, and we're working toward that.
Okay, thank you. You also spoke about data, that there's not a lot of data on Black, Indigenous, and people of color. Do you think that would you recommend a federal investment, a major federal investment to do more research geared on breast cancer as it impacts Black, Indigenous, and people of color?
Absolutely. This is an urgent need to collect these data and to add this to how we track breast cancer and other cancers in Canada so that we know who is getting the breast cancer and at what stage.
Okay, I only have 25 seconds left. Dr. Apavu, you mentioned that you have a list of recommendations for the task force. Could you please submit those recommendations to the committee?
I will.
Okay. And do you believe that sexism is impacting decisions made or has impacted decisions made by the current task force?
In all fair, I think it's equal opportunity bad guidelines. The prostate cancer guidelines are similarly distasteful to people who know about prostate cancer. So I would have to say I don't see it as being specific to gender. I see it being as specific to incompetence.
Thank you.
Okay.
Thank you, Leah. Okay, next we have Michelle for 5 minutes.
Thank you, Madam Chair. Thank you so much to our witnesses for this really important study. Thank you to my colleagues for sharing their personal stories. There's certainly no shortage of people who've been impacted by this breast cancer. So we're here. We're trying to get some information about screening at an earlier age, and in particular 40. If I can start with Ms. Farber, who has shared her personal experience of being diagnosed. You wanted a mammogram at 40, but you were discouraged. What was the reasoning for the discouraging?
So I always, when I talk about this, I want to really make it clear that this wasn't a case where I was advocating hard and my doctor denied me of something. This was something where, like every year, I go to see my family doctor, and there are certain things that we have done. For example, a PAP. Which, by the way, I've never been asked my personal preference or my values, but whether or not I want to have a PAP. So that's kind of interesting to me. It was just, here's the things that we need to do. We need to do blood work. You need to have your tetanus shot. Me, do I need to have, a mammogram? I'm 40 now. And the response being no. The Canadian guidelines now say that you don't need to have one until you're 50. And I asked again later on, I believe when I was 45, and received a very similar response. It was a very casual discussion, and I think that that's probably more reflective of the type of conversations that are happening between patients and doctors in busy family doctor offices. So, yeah, it was just a sort of, and I was also told I had no family history, and therefore I was very low risk, which I have now found out is not true. We know that the majority of breast cancers that are found in women without a family history.
I think what's interesting there is how you kind of rationalize that you didn't have to advocate hard. I find that bizarre when we're dealing with our doctors, that it's our body, we live with it all day, and yet we have to sort of fight to be heard. I feel that a lot from folks. To Dr. McCurley, you had said the guidelines currently are based on a study from the 80s, and this study is flawed. How is it flawed?
Thanks for the question. So there were a number of things that went on, including a randomized control trial is supposed to be the gold standard. There were issues with that randomization, and there have been papers that have shown that to be the case. There have been papers that shown that to be the case, and there were other issues as well as that non-randomization. But of course, one of the main things, even if the study was equal and perfect, is the fact that they used 98% of white women, which in the House of Commons last time, Dr. Narrett agreed to, and that we know is not reflective of Canadians' population today.
Thank you. Thank you for that. I think what's kind of shocking for a lot of provinces is you can only get a screening mammogram if you have a referral from family physicians. 1 in 4 Ontarians are without a family doctor. 6.5 million Canadians don't have a family doctor. And, now on the Ontario website too, it says, if you don't have a doctor, phone this number, like you're going to get one. I think that's pretty hysterical. But this is a big problem. And I know you can self-refer in some provinces, that's changed. But the reality is if the wait list is too long and there's a backlog, what does that even do? So one of the questions I have, and whoever wants to answer it, I guess I'd look to Dr. Rushton. If we move this number back to 40, right now, even say it is 50, but you don't even get it at 50 because there's not enough doctors. There's not enough spaces. So I think even moving it back to 40, you might not even still get it at 40 if I'm being correct if I do the math. So I'm not sure who wants to. I'm going to.
So Michelle, just if I
Maybe
may,
I could take it.
There are 3 individuals. If we be mindful of the screen behind you that do want to chime in. I don't think you can see it from there.
I'm happy.
I was just going to say that I'd be happy to comment on that. It's a great question, and it addresses some of the concerns from Manitoba. In Ontario, we are allocating resources to increase the screening program to include women in their 40s. We know, based on British Columbia and Nova Scotia data, that the first screen has the highest abnormal recalls, and then it drops to the same as if you're in your 40s, 50s, 60s. It's not higher if you're in your 40s. You do need to allocate resources, but that is, we are going to be able to do that in Ontario by increasing training of technologists, more mammography units, and more access to these diagnostic tests.
Thank you for that. I know we have a lot of information that we're trying to get out. Unfortunately, 5 minutes has exhausted. If any of you could submit any additional information that you have in response to that question, that would probably be helpful for the analysts. Next, I'd like to welcome Anita. You have 5 minutes.
Thank you very much. And I just have to say, I think this is probably one of the most impactful panels we've had in this committee. And I am incredibly grateful that we have had the ability to create the platform to bring your voices into a process that clearly has been lacking those voices. Ms. Farber, I just wanted to say to you, I have a feeling there's a lot of us around this table and those that are watching who are thinking was precisely what you just described. I think you're describing what is probably, in reality, the lived experience of most women. So thank you so much for that testimony. I'm so sorry for what you had to go through. I want to start my questions with Dr. Seeley, because you mentioned that the task force was looking at obsolete technologies, old reports, sometimes decades old, that it ignored recent observational trial data that said, I think you said 2.6 million women in that. I just wonder if you could elaborate a bit on the methodology and the reports and the actual data and information that was addressed by the task force and how that may have led to the flawed results of the task force.
So one of the recommendations that we, myself and 2 other expert advisors, made to the evidence review team is that using the old randomized trials would really be an error in looking at the new evidence. And the reason for that is that the methodology called GRADE that Dr. Apavu referred to automatically characterizes that as the highest quality evidence. So it doesn't matter if you include another 90 studies after those randomized trials, it automatically downgrades them. And what we showed in our evidence review is that if you looked at the observational trials, the benefit of reducing mortality was 50%. It is a huge benefit. But if you only looked at the randomized control trials, it lowered it to about 20%. So this methodology that was insisted on by the task force downgraded all of these very large, extensive trials that included more modern treatments. So that was one of the points that we had recommended that they disregarded.
And you also said something briefly about that you had a non-disclosure on inputs that you would want to provide to the task force. Can you elaborate on that? Because that seems quite not transparent.
So the task force had a call for experts to be consultants and advisors, but the condition of being one of those advisors had to be that you signed a form that removed any possibility of you disclosing what the process was and was involved with. These experts also were non-voting members. I decided that that was a risk I was not willing to take, but I was able to work with the evidence review team and to really see what the working group was insisting on by this evidence review. So I could see their really interference and direction that really hampered the evidence review team from doing the work that had been proposed, which was to look at the recent evidence, which was what was done in the United States. They only looked at studies from 2016 on. This protocol was not adopted by the working group, and I think is one of the reasons we have these recommendations.
So in fact, there was a disincentive for experts to participate in this. That's quite alarming. I did want to go quickly to Ms. Van Dusen because
Anita, and just so you're aware, Dr. Turner does have her hand up as well. I didn't know if you saw it.
Okay, yeah,
Okay, thanks.
I want to try and get to
No,
as
of course,
many as
yeah.
possible, but I did want to ask Ms. Van Dusen quickly about international data. You said that there was international evidence that was not taken into account. Could you explain that?
We have a whole list of data that we informed our recommendations on, both in Canada and internationally, and I'd be happy to provide that.
If you could actually in writing submit
Yep.
that. And it was Dr. Turner, I guess, who wanted to speak? I can't see.
Yes, just really briefly, just did want to note that I really would encourage people to go and have a look at the task force's website. They did collect information on feedback that they had from people, including their responses. And as you know, that these are draft guidelines, and they are right now they are currently open. And I think they have been quite transparent when you look through about the studies that they included and they didn't include, and they've expanded their look. And I think actually that's one of the reasons why the discussion around 40 to 49s has actually been something that is actually more on the table now in terms of enabling people to have those conversations. So I just wanted to encourage folks in that direction.
I'm so limited in my time, and I did want to go to Dr. Apavu because.
So Anita, I'm sorry to share with you. I tried to get it an extra 30 seconds, but it's not working. Okay, so because of the efficiency of all of you around the table, we do have time for an entire fourth round. So I'd like to start. Anna, you have 5 minutes.
Thank you, Madam Chair. I'm going to ask everyone a simple question, and that is, do you consider it to be a risk, according to the task force, family history, carrying the mutation gene BRCA1 and BRCA2, or have dense breast? If everyone could just say yes or no, that would be great. Yes?
Yes.
I think we all agree with that? We're all in agreement? Okay.
Dr. Turner has her hand up.
Donna, does she not agree with that?
I don't know.
Yeah, no, I do agree. And I just want to note that is increased risk. Those are not average risk, which is what the guidelines
Increased risk. Okay. And so would you agree that if that is the case, there should be mandatory genetic testing? Yes or no? Yeah, just a yes or no from everybody?
No.
No, I think risk assessment should be done, and that's very important, but not necessarily genetic testing.
Okay. And, okay, so I just did some research on from the Cancer Society. So cancer is the second cause of death among women. That is 25% of new cancer cases in female. In 2024, it is estimated that 5,500 Canadian women will die. 15 women per day will die of breast cancer every day. This is something that I think all women, all of us, feel that in order to prevent the mortality rate, we should push the task force to increase the testing at age 40. Does everybody agree with that?
Yes.
If I could just make a comment.
Sure.
Unfortunately, the genetic testing only identifies 50% of women at high risk, and the majority of women do not have any risk factors that would tell them that they're at high risk. So they wouldn't carry the genetic mutation, but they would still get breast cancer. Risk assessment is what we're recommending, starting at age 25 to 30, as a way to demonstrate when they should start screening. So I think that is really an essential component that we should be recommending, and this guideline did not address that.
So would you say that the task force needs to be updated with the more pertinent information? Because I'll be quite honest with you, as a woman, these numbers scare the hell out of me. And I think I'd rather know early, how do I prevent cancer, or how can we detect it in the early stages so that I have a long enough life to see my grandchildren grow? Anyone can answer.
If I can speak in, I think we have to look at, there's no one, everyone around here wants there to be no breast cancer deaths. And so how do we achieve that? Screening has a very important role in that. So does advancement of treatments. I think there is a role for certain populations to have better access to genetic testing and prevention. Prevention itself has been largely understudied and poorly studied in breast cancer. But just the task force recommendations itself is a very limited single tool. And whether or not we should move from 50 to 40, we have a multitude of different views around that, which I won't get in for brevity. But I think it's always important to know that actually over 90% of women with breast cancer in Canada will be cured.
Okay, so not to cut you short, but I do have a limited time. I'm so sorry. Is there a fee for genetic testing?
There is a fee.
And can you tell me what that would be?
Yeah, so if you want private genetic testing, so if the government pays for it, each government will have a different not fee to patients, but how much it costs them. If you want to, in my practice, I do counsel patients who aren't candidates for provincially funded breast testing to pay for it itself. In the two groups that I tend to lead them towards, the last time I looked, it was $299 US. And that is a sort of a common ballpark for genetic testing that someone would pay for out of pocket, but at a medical grade lab.
So what I'm thinking here is, if I had a situation where there is a family history of it, and I would try and find the money somewhere to help the individual get that genetic testing, if we could avoid. So the challenge,
if you don't mind, because I think this is of getting genetic testing always works best if someone in your family who's had the cancer is the first one to get genetic testing. And actually across Canada, which would be a whole other discussion for us, there is varied landscape of how easy or how hard it is to access that testing, and provincial guidelines do not agree. When you haven't had cancer and you opt for a genetic test, then there is some nuance to it, because if you come back with a gene, that's helpful. But if you come back without a gene, it doesn't tell us, is your family carrying a gene and you didn't get it, so you're actually relatively low or population risk? Or is there something else going on in your family? All the mix of small genes that we can't measure, lifestyle choices, our environment that goes into your risk, and you still are at elevated risk for breast cancer. So testing people who haven't had cancer comes with difficulty, and that's where our medical genetics colleagues are really important in that. And I do think it probably, I'll stop now because it's
Thank you, Dr. Havard. Thank you. And thank you, Anna. Mark, you have 5 minutes.
Thank you, Madam Chair, and thank you to all. I just want to echo what was said earlier. This is probably, I've been here on the Status Women Committee now for 7 years, and this is probably the most insightful panel of witnesses that we've had. I mean, we've had some good witnesses in the past, but I want to thank you for the work and thank you for the commitment. And also, it's shocking, I think, what we're hearing today. So I want to ask, there's a few, and Dr. Apavo, you know, we talked about the guidelines of the U.S. and some of the recent evidence that we're not even that the Canadian Task Force didn't take into consideration. So I want to talk about that. But first, you talked a bit about the composition of what the membership should be. Can you enlighten or your recommendation on the committee here what the composition of the task force should look like? There seem to be some issues there.
Yes. Right now, the task force is deliberately made of people who are not content experts. So they are experts in their own fields, you know, but they are not experts in the topic that they're handling. And they do that because, again, it's this idea of not having skin in the game or not having bias or conflict of interest. But I think that it's throwing out the baby with the bathwater, because then you not only eliminate bias or at least specialist bias, you don't eliminate bias because they're biased. Everybody has bias. In my opinion, it should be, and I think this is probably what most Canadians believe to be true already, experts in the topics leading the guidelines and methodologists at their side assisting them, sort of shoulder to shoulder, working together towards good guidelines for Canadians, and not this idea of leaving the experts out of the room. I always liken it to school kids marking their own homework and shutting the teacher out of the room. You know, they give themselves good marks, so they seem well. You know, they've got good marks, and but they don't know what they don't know. And unfortunately, they need better guidance from people who do understand the context and the nuances. And you cannot use a blunt tool like grade, which allows you to include, you know, only, for example, not diverse data, and expect to get good. You know, it's a very blunt tool, and expect to get a good understanding of what the nuances are.
Thank you. And Dr. Paul, you mentioned about the studies on cervical cancer and others, and I want to ask Dr. Rushton and Dr. McKeely, we've seen other reports that women's health, you know, general studies have been at the bottom of the list, either from NSERC, university studies, government studies, and it seems like we have the group here from Manitoba. It seems to agree for the task force recommendations, but in general, the data seems to be either it's not there or it's not being looked at. What are your recommendations to the federal government here, the committee, to really? I know there's more money needed for women's health on the study side, but what recommendation? What seems to be the glitch here between the task force and the lack of studies, or not even following the U.S. guidelines?
And MP Saray, you do have two individuals online as well, if you'd like to engage.
Okay, I'll do. Okay.
Yeah, I'll be brief. So I think one big gap that I would like to identify out loud, and I can send more information, is the disutilities that are used to assess the quality of life that is gained with early detection. I was looking at this recently for the disutility, so if you've treated someone for a cancer in health economics, you'll apply a certain what percentage of quality of life are they living during that treatment period. And for breast cancer, and probably for many cancers, but I don't treat those, so I just looked at breast cancer, the disutilities during the treatment period are very finite and really limited to a very short period of time, which really does not reflect the patient experience. So I think if there is going to be work done, it would be looking at the disutilities of the real quality of life and the long-term quality of life impacts of our treatments, which span, you know, in some cases up to a decade after a cancer diagnosis.
Shira Faber, quickly, 30 seconds, please.
Yeah, I just really wanted to address quickly this idea that the task force is objective because they don't have skin in the game. With all due respect, the task force has been lecturing on social media, interviewed by the press, published papers about the myths of benefits of screening and the harms of screening this entire time. at least the specialists are specialists in that area. As a patient, that's who I would like making decisions about these guidelines, not people who are propelling their careers and their academic careers based on something called the myths of screening.
Thank you so much.
Debunking screening.
Thank you.
If I could
Next, we
just
have
add one
Adrienne LaRouche. You have 5 minutes.
Thank you very much, Madam Chair. So once again, it's probably my last chance. So thank you to the witnesses for being with us today. I appreciate it. It was instructive and disturbing, I'll put it that way, to see what is unfolding at the moment. Ms. Vanderson, I'd like to hear from you, as well as from Mr. Reynaud from the Canadian Cancer Society. There's an article that came out at the beginning of May that was asking for the age to be reduced to 40, and you had a press conference on that. So you felt the need to come out in the media on this issue. So you're part of the number of the people who weren't consulted by the task force, and you've asked for this change. And in the article, it said that the Canadian Cancer Society does important work. We're looking forward to working with them and to examine the evidence later. So I imagine that you're still waiting to have an exchange with the task force. You haven't had any news from them. What would you like to discuss with them, according to this newspaper article where they said that would happen?
It's a bit of a difficult one. We want to keep working with the task force while they are in the position that they are to create the guidelines that they are creating. We do think that improvements were made since the last iteration, and we appreciate at least the acknowledgement that women that want access should have access. We just feel that that doesn't go quite far enough, as far as it still places the onus on women to, again, know that they have access to breast cancer screening and ask for it in a context in which we've acknowledged many Canadians don't have access to healthcare providers. Or we've also heard today that, if it's not the standard, then you think maybe you don't need it. And so it undermines the inclination that we need care. So we will continue to work with the task force whenever possible. We have echoed calls from other organizations to increase transparency, but obviously there are concerns with the way this has all transpired. I don't know if you have something to add, Helena.
Really briefly, we also really hope that the public consultation that they are currently going through as a result of these guidelines will be made public.
Ouais, puis très rapidement, je rajouterais aussi.
Very quickly, I would add that for us, it's important for us to see people affected by cancer, that the patients and their experiences be reflected in these studies, and that we take into account the experience of people affected by cancer. That's at the root of our work. I still have some time? Oh, I thought I only had 2.5 minutes. Wonderful. Well, sorry, there were people who raised their hands earlier, and thank you for pointing that out. Sorry, you, Ms. Van Dusen and Mr. Reynaud were consulted, but we spoke with Ms. Sonia online too. But thank you for that clarification. You hadn't answered my question earlier as to whether you'd been consulted or not. So I'd like to come back. Mr. Reynaud and Ms. Van Dusen, there was also mention that these are guidelines, and that afterwards we give women the possibility, and earlier someone said in answer to a question that they don't want to interfere or prevent women from having the right, those between the ages of 40 and 50. We don't want to impose something, but we should say that women have the right to have this test. So that was in the article. It's important to clarify. Do you have something to add to that? I can see you're nodding, Ms. Van Dusen. Well, what you said, that the importance of hearing you on the fact that the guidelines for those 40 to 50 are not imposing anything, but we want to offer women the choice.
But if they create a barrier to other provinces to make this decision, I think that's a problem. I also think it's a problem if doctors are individually using this as a recommendation in how they operate in their own practice. And so if you do happen to be lucky enough to have a healthcare provider and your doctor says you don't need access because the recommendations don't say so, then you happen to be out of luck, or you are forced to look elsewhere for somebody who will support you in that feeling or inclination that perhaps you should be receiving screening earlier.
Excellent. Thank you so much for that, Leah. Last 5 minutes.
Thank you so much, and and thank you to all the witnesses today. Like, it is just so shocking to me that people making decisions about life and death matters are not experts in the field, and this whole notion of bias. Like, I spent almost 20 years in academia. There is no research that is unbiased, and you have to identify that bias. Like, it is a non-relevant argument, in fact, that's being used. I find it horrifying. I also found it horrifying, Dr. McKearley, that they're using research from the 80s that was done with 98%, that was comprised 98% of Caucasian women. If we want to talk about bias, I mean, that's screaming bias to me. Would you, do you think that it's necessary, would you recommend that the federal government make major investments in genetic research to identify hidden genetic factors, particularly for Black, Indigenous, and people of color?
Yeah, thanks for that question. And yeah, I would absolutely agree. Right now, there's a lot of research that's going on in the States that does show that a large part of the issue in racialized population, especially Black, relates to genetics. And there's a call for racialized women and Black women to engage in those clinical trials. So absolutely, I would agree there needs to be some investment in that, especially in Canada.
Thank you very much. My question is for you, Dr. Apovo. You spoke about people on the task force currently are not experts. Can you expand on that? I want to understand at the level they are not experts, like who is on this task force? I would never put myself on the task force, for example, right?
Yeah.
Okay.
And again, I want to give them their credit. They're experts in their fields, but their fields are not the fields of the guidelines. So, for instance, the 2018 breast cancer screening guideline was chaired by a nephrologist or a kidney doctor. The guideline this time was chaired by a family doctor. Now, they are experts in their fields, and they're experts in guideline methodology. But I think guideline methodology needs to be the assistant to the guideline. You know, we need to have methodologists helping make guidelines, not completely making the guidelines without any expert guidance and without understanding, for instance, nuances of the disease behavior, nuances of treatment, and so on.
So I ask that because we're all experts in something, I'm an expert in adult education, right? So I'm certainly not questioning their qualifications as an individual. What I am questioning, however, is their qualifications to, as an expert, to make decisions about matters outside of their expertise. So would you say that their expertise falls outside of the expertise related to cancer, certainly breast cancer, yes or no?
Yes, there's something called epistemic trespassing, which is, the phenomenon of somebody who's, say, a doctor of geology talking, this happened during the pandemic, a doctor of geology talking about vaccines. They're a doctor, but now this is definitely not the same case. They are experts in medicine, but they really have no expertise in the areas that they're making national rulings on. They're basically practicing specialty medicine out of their fields.
In your last minute, Leah?
Okay, thank you. Very, very troubling. My last question is for Dr. Seeley. You did do genetic research or research on genetics. Why wasn't it accepted? Like, I still don't understand this. It was like over 2 million women. Like, what was the argument for it not being accepted? I find this shocking.
Again, that has to do with methodology. So the use of randomized trials always takes precedence over a study as large as 2.7 million women. It is shocking. I completely agree with you. And those recent studies looked at more modern diagnosis and treatments using the more up-to-date technology. And this, I think, has to do with a lack of expertise and the lack of knowledge about what screening is and how it functions in Canadian programs. Canadian programs are extremely well run. We monitor the abnormal recall rates, the positive biopsy rates. All of that was done and shown in this beautiful study. But because we didn't have experts who understood the impact of this, it was downgraded in favor of the randomized trials that were 60 years old.
Okay, thank you very much for that.
I'd like
to thank all of our witnesses. This does conclude our meeting on the breast cancer draft recommendations. On the behalf of the committee, I would certainly like to thank all of you for your testimony and contributing to our work as a committee. A reminder for all members, next Tuesday, June 18th, we will be studying